Hello, everyone, and welcome to today's Keynote webinar titled Laboratory Assessment of COVID-19 Immunity in Patients with a Cancer Diagnosis, Alpha to Omicron. This webinar is a part of the 10th Annual Genetics Virtual Week. I'm Antonina Salcido of Labroots, and I will be your moderator for today's event. Today's educational web seminar is presented by Labroots. Now let's get started. Before we begin, I'd just like to remind everyone that this event is interactive. We encourage you to first participate by communicating with other attendees using our new live chat feature during the presentation. You can find the live chat located at the right of your screen. You can also participate by submitting as many questions as you would like during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Help Desk button located at the bottom of your screen within the navigation bar or from the lobby. Finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits link located in the abstract window below the presentation window and follow the process to obtain your credits. I now present today's speaker, Dr. Balazs Halmos, Professor of Oncology and Associate Director of Clinical Research at Albert Einstein College of Medicine at the Montefiore Medical Center. For a complete biography on our speaker, please visit the Biography tab at the left of your screen. Dr. Halmos, you may now begin your presentation.
Thank you so much, Antonina. It's such a pleasure to be here today. I was just peeking at the attendee list, and I just wanted to shout out to the international audience. Being from Hungary myself, I see some neighbors from Romania, from the Carpathian Mountains. So hi, everyone. Please be engaged with some questions at the very end. The topic of the presentation is about COVID-19 and the patient with a cancer diagnosis. But basically, I'm a practicing medical oncologist, so hope to field any questions related to oncology. I know that this is a precision oncology, precision medicine day for you guys, so happy to kind of open up the discussion that way as well. But our topic basically is COVID-19 today, and the reason being is quite simple. I'm a thoracic oncologist who had nothing to do with infectious disease until March 1 of 2020. But March 1 of 2020, the first patient with COVID-19 got diagnosed in New York City, where I practice at an institution called Montefiore Medical Center in the Bronx, which is one of the large boroughs of New York City, also the poorest one. And our institution serves a very diverse patient population, with about 80% of our patients coming from key minority groups such as Hispanics and African Americans. And as you guys might remember, COVID-19 hit New York City very, very hard early on, and especially had a major impact in our patient population of the underserved in a way. So as an oncologist, it came as a huge giant wave across our practices, and we all needed to kind of dig in deep and figure out ways to face this. And just to highlight, this tiny virus, with tiny mRNA molecule, 28 kilobases or so, coding for just a few dozen proteins, brought New York City to its knees at that time. Our first patient was diagnosed on March 11 of 2020, and within 3 weeks, the hospital became completely full. The hospital system has 2,000 inpatient beds, and basically 95% of all of our inpatient beds were filled with patients suffering from very severe symptomatic COVID-19 at the time. This was the start of the pandemic, as you can imagine. Only patients, super ill, came to the hospital, got diagnosed. And within the next 3 months, we had more than 10,000 patients with COVID-19 in our hospital system. And many of those patients came from our practices, patients with different types of cancer, not being diagnosed with a severe and really, ill-defined illness at the time with COVID-19. So this posed a lot of serious challenges early on in terms of how we kind of managed, through this incredible chaos that COVID-19 brought. It also brought a couple of kind of, funny and also uplifting moments as well. This actually is an incident from, end of March, when of course nobody could, get an N95 mask, but we needed to protect our patients, we needed to protect our nursing staff and ourselves as well. So everybody was scrambling from N95 masks. and they found a secret stash in some warehouse in New Jersey. And who did they send to pick it up? Myself, because our charge nurse felt that I was someone with experience who could take care of business. So I was bringing in N95 masks from ugly warehouses from New Jersey to our institution in the Bronx. But at the same time, we also received some incredible gifts. Actually, on the right side, you can see this kind of funny gift from Hong Kong, sending masks, to the patients of New York City and then nurses, healthcare providers of New York City, wishing us to make America healthy again. So, nice and uplifting moments in this first couple of weeks of the pandemic. But ultimately, as a practitioner, it's really kind of highlighted the need of, for our healthcare workers to show our compassion, show our ability to reach out and help our patients in need, even in the most desperate times. And that's what we as an oncology practice at that time decided to do. First of all, dig in deep and try to find ways, even in the middle of this terrible chaos early on, to get care for our patients. And that could be defined by the strategy that we built at the time, the cancer patients PPE, prevent, protect, and enable, preventing them from getting infected, by shifting them to telemedicine, holding treatments when they were not necessary, protect them through the pandemic by providing proper precautions, from day one up until now, alter treatment regimens as much as possible within reason, and separating uninfected patients from COVID-positive patients at the time, setting up different infusion centers, etc. And lastly, and most importantly, enable patients with a cancer diagnosis, especially advanced cancer, life-threatening disease, cannot just be treated through telemedicine. We need to figure out ways to provide cancer therapy, provide testing, et cetera, but also continue with research because future generations of cancer patients cannot wait either. And of course, in the Bronx, New York City, we also need to be certain that we bring all the potential benefits to the patients most at need, the most vulnerable, the patients that we took care of. So many institutions, including ourselves, kind of switch strategies, and this just shows a nice guideline actually from the UK in terms of kind of risk stratification for patients as to who can wait and where there's a more immediate need, where we still, despite the fact of active waves of the pandemic, needed to go on with a much needed therapy. So as we set up our practices in the first place, myself and a couple of our colleagues decided that as cancer researchers, we will just not set up ways to manage our patients through the pandemic, but we'll do our very best to learn from the pandemic. And New York City being hit so hard so early, we felt that we were in position to maybe warn other institutions across the world as to how to approach, how to manage patients with COVID-19 with a cancer diagnosis, and published basically the first U.S. cohort experience of patients with a malignant diagnosis and COVID-19, gathering 200 plus patients from our institution within the first month. This is April 2020, identifying a very high percent mortality, 28% at the time, recognized that this was the first wave. So again, very symptomatic patients just being rushed to the emergency room, being intubated, came in. So no wonder that mortality was higher than what you're seeing subsequent data sets. But what was more important is that mortality seemed to differ both in terms of the type of malignancy. Patients with hematological malignancies and lung cancer seemed to do worse than others. And there also were very, very prominent associations with clinical features such as comorbidities, performance status, as well as age. So very elderly, multiple comorbidities, etc., did a lot more poorly than a patient who was younger, without a whole lot of comorbidities. And of course, this first observation has been carried through all the waves of COVID-19 ever since. It's kind of the key predictors of a patient's outcome, with COVID-19. So this kind of summarizes this experience maybe a little bit better as to percentages, and the case fatality rate, as I mentioned, was 28% on average, 37% in patients with hematological malignancies. Not too surprising, these are the patients who are most immunosuppressed, maybe with a lymphoid malignancy or post bone marrow transplantation. And out of solid tumors, the mortality was highest amongst patients with lung cancer. And again, maybe this is not a surprising finding if you think about it a little bit. That's of course number one. The spike protein of COVID-19 binds to the ACE receptor on the airway epithelial cells infecting the lung. And of course, our patients with lung cancer might have limited lung function related to lung surgery, related to prior lung disease such as COPD, emphysema, and also could have damaged lungs as a result of treatment such as radiation, for example. So no surprise that they will be impacted the most significantly with a respiratory virus causing a viral pneumonia. At around the same time, in March of 2020, a single tweet initiated a global collaboration called CCC19, starting between Dr. Desai and Dr. Warner. And as we learned from our cohort, we decided to quickly contribute to this international global consortium. And the first data set from this consortium, and I just hope that you please see the slide, looking at 30-day all-cause mortality was published a few weeks afterwards in Lancet. And what you can see here is this was the median age of this, again, international, mostly US-based cohort, with 82% of the patients, with solid tumor diagnosis, 20% with hematological malignancies. And what you can see here is that the outcome, was certainly very serious. 13% of the patients died, a smaller number than, our first cohort. This is now suddenly testing was more available, so less symptomatic patients could be diagnosed. But when a patient had to be hospitalized for COVID-19, the case fatality rate was up to 50%. Again, incredible impact for that particular patient cohort. What was very impressive in a way, from this study was the incredible spread of outcomes, though. If a patient had a good, performance status, physical condition, didn't have, comorbidities, basically the chance of death was close to 0%. On the other hand, if a patient had a poor performance status, especially if they needed intubation for management of their COVID-19, almost all of the patients succumbed to this serious illness. Further major risk factors for poor outcome, just like I mentioned previously from our initial cohort, now from thousands of patients, confirmed and expanded for older age, poor performance status, active or progressing malignancy, and also hematological malignancies, just like I previously mentioned. This study was also able to highlight some impact of ongoing cytotoxic chemotherapy leading to worse outcomes. Here you can see now a follow-up of this study, now focusing on, I think, about 10,000 patients and later studies of the same cohort. Breaking it down, with more accurate percentages in terms of patient outcomes. As you can see, just like I mentioned previously, logically, lung cancer and lymphomas, come out on top of any of these lists. Another cohort study that we collaborated with very early on and continues to actually produce, really interesting and relevant data is the terrible study initiated by two leading female physicians, Marina Garassino from Italy and Leora Horn from Vanderbilt University. And it has been expanded into this international collaboration of thousands of patients with a lung cancer diagnosis, looking at outcomes with COVID-19. And what you can see here is that now looking at a lot of clinical and laboratory factors, a very specific nomogram could actually be built, focusing on a major negative predictors of outcomes such as elderly age, certain laboratory factors such as C-reactive protein, procalcitonin, performance status, etc. So again, just give a guidance to the when somebody has multiple of these negative risk factors. So all in all, the picture I think has become complete fairly early that, for a patient, with a cancer diagnosis who catches COVID-19, poor outcome is influenced by a number of very definable factors helping clinicians to guide patients through this phase of the pandemic. I mentioned advanced age, poor performance status, advancing disease, laboratory markers, immunosuppression, comorbidities, being kind of major predictors of outcome. At the same time, as we learned about, I have to kind of guide patients through this pandemic who needs to be protected more than others, we suffered a lot of secondary damages from the pandemic. Of course, life, got shut down as we know it basically for months between waves and waves and waves of COVID-19, leading to major impairments of actually being able to diagnose cancers and treat cancers. Of course, cancer remains one of the leading causes of deaths around the world, as much as COVID-19 has become the most prominent problem for mankind the last 2 years. So we cannot forget about being able to diagnose and treat cancers, for millions and millions of individuals around the globe. And, we suffered a lot of damage over this period of time. There's been a dramatic drop-off in cancer screenings, as you can see here. And these delays, cancellations of cancer screenings for millions of individuals now is leading to a higher number of patients being not diagnosed at more advanced stages of their illness. And what that leads to is an erosion in the improvement of outcomes that we've seen the last 30 years. The last 2 years, likely we'll see worsening of cancer-related mortality as a result of less early-stage patients being diagnosed. So we have to do our very, very best to prevent this bleeding, to prevent this damage, through many, many different ways. Again, this just shows you the number of, the lesser number of patients being diagnosed with certain cancers over the early period of time, again, leading to more advanced stage cancer patients being diagnosed later on. And here you can see in this slide both the 80-90% drop-offs in cancer screenings for long periods of time, as well as basically a 50% drop-off in clinical trial accruals, and that will slow down research that could improve patient outcomes in the coming years. So a lot of issues, where we needed to make, quick fixes. And of course, one way to make quick fixes was to learn more about, how immunity against COVID-19 develops, and ultimately, as vaccinations came about, how to use them to our best advantage. And of course, adaptive immunity we know a lot about, and as you can imagine, a respiratory virus infecting every epithelial cell will lead to ultimate immunity in the patient surviving it through the activation of dendritic cells, those migrating to lymph nodes, and ultimately antibodies being generated, and both B cell, humoral, and cellular immunity being developed, and hopefully a long-term imprint, in terms of memory, B cells and T cells being present in our patients as they survive the infection or as they get immunized, with COVID-19 vaccines. Here you can just see the timeline after natural infection with COVID-19, the rise, in terms of virus and antigen that can be detected, quick rise and then quick disappearance afterwards, with the appearance of antibodies, anti-nucleocapsid, as well as other antibodies that we can detect, and then ultimately more specific T cells and memory B cells. So at that time, as we kind of went through this first wave of the pandemic, and we felt that we contributed some piece of information to the world in a way, but that the information was bad. COVID-19 is a serious disease. Many patients die. I felt uncomfortable to kind of not try to make more of an impact in the field, and just going back to my routine as a thoracic oncologist. And with our colleagues, we decided to take a different look at that time. Look at the survivors of COVID-19 from our institution, and look at the immunity that they develop. Can we identify if patients with a cancer diagnosis will develop detectable immunity, and will there be certain patient subsets where maybe this immunity is not as good as in others, and could there be potentially a warning for the upcoming vaccinations? This study was done exactly at the time that the first vaccines were just about to be approved, so that we can dig in and do research now for patients who get vaccinated as to what to anticipate. So this study, focusing on 260 patients we identified from our healthcare system with a range of malignant cancer diagnosis, and again a range of diverse patients, 40% African American, 40% Hispanic. What we've identified was actually quite intriguing. What we've seen is that, first of all, 92% of our patients had positive nucleocapsid antibody. The expectation is 100% in a normal healthy population, so very close. So immunity seemed to develop in most of our patients who survived COVID, except for a small subset, 8%. And when we looked at that 8%, who are the patients who don't develop immunity, what you can see on the right-hand side, this was very definable in a way. Most of these patients had either hematological malignancies or had undergone very specific, highly immunosuppressive treatments, such as anti-CD20 therapy, that's a B-cell kind of poison in a way, rituximab, anti-CD20 antibody being the most commonly used drug in this class, as well as stem cell transplantations, highly immunosuppressive therapy, of course, impairing vaccine immunity to a range of vaccines. So after bone marrow transplantation, we need to revaccinate our patients with everything. So again, not a surprise, but nice to see it documented in a way, as well as after CAR T-cell therapy. So, we learned that there were some potential definable risk factors as to who might or might not respond to vaccinations. And we were fortunate to have good leadership at our hospital. So basically 2 weeks after the vaccines were approved, we were able to make them available to our patients with a cancer diagnosis. There's an email from January 2021 where our chief medical officer asked us just to give them a list of patients who were the most immune suppressed, patients with cancer that we were really concerned about. And they called our patients in one by one to get to the front of the line to get vaccinated against COVID-19 with the Pfizer, Moderna, or the Johnson & Johnson vaccines as they became available in the United States. So as we did looking back, a very good job, fortunately, to vaccinate our patients very, very early, we also learned soon enough that there's studies from other cohorts of patients identifying some patients who will not respond to the vaccines. This is coming from the transplant literature. The first paper we saw from Israel, where vaccinations came out the fastest. And we said, well, we vaccinated our patients in January 2021, probably the earliest on the planet in a way. Maybe we can learn from those patients as to how they developed immunity. And that's the next study that we set up. And this is now looking at 200 patients who received vaccinations, routine vaccinations. And a few weeks afterwards, we just did a cross-sectional study, basically with each of our trainees, hem-onc fellows from our second-year fellowship group contributing with the recruitment of patients, and just looked at their spike antibody levels to see, have they developed detectable immunity, and then quantified it also in terms of titers of those antibodies. Just like previously, living and working in New York City, we have a very diverse patient population, and they had a range of, solid tumors and heme malignancies, prior therapies, as well as, half of them got the Pfizer vaccine, 30% Moderna, and 10% Johnson & Johnson. So we had all three of the vaccinations represented in this cohort as well. And what you can see is that the large majority of the patients actually did respond to the vaccine. They did develop antibody, anti-spike IgG positivity, as you can see on the right side, 98% of solid tumor patients, but only 85% of hematological malignancies. So 85% is nice, but it's not 100%. So who are the 15% who didn't convert? We kind of knew where to look, based on our previous data, and just as you can see it, exactly as you might have predicted, patients who received highly immunosuppressive therapy before, anti-CD20, stem cell transplantation, CAR T-cell therapy, had a much lesser chance of conversion. In fact, a very small number, but still important number of CAR T-cell therapy patients in our cohort, none of them converted on the level of antibody positivity. Now here we had a chance, to look at titer levels, as a laboratory now, was willing to work with us to generate actual titers. And what you can see here is that yes, indeed, as compared to a control group of healthy individuals, basically our solid tumor patients developed antibody titers almost at the same level. But as you can see, hematological malignancies, the titer levels are much, much, much lower. So they might be positive, but they might be positive at a much lower rate. And as we've learned, since, that can lead to a higher risk of breakthrough infections and more serious breakthrough infections, as you can imagine. But we also saw, and this was a nice kind of mirroring of the literature from other data as well, that there were some differences between the vaccines. The Johnson & Johnson vaccine did seem to perform the least well, while Moderna seemed to be kind of at the top of the line as to efficacy of these vaccines. And when we looked at the very specific cohorts of patients, what you can see here again is quite striking. The CAR T patients, anti-CD20, really stood out as kind of the last stragglers in this cohort in terms of being able to develop any type of detectable immunity. Going further, of course, many of our patients will receive other types of treatment nowadays, and they can be, hormonal treatment for breast cancer, or prostate cancer, or checkpoint inhibitors, for lung cancer or melanoma. Unfortunately, those types of treatments had no influence, or if anything, they seem to maybe even, make these, titers go up. And that's very reassuring news for a large majority of patients with a cancer diagnosis. These vaccinations tend to work really well, just as expected otherwise. And then that we felt was very good news. And again, just going along with the literature, kind of an unexpected pool of patients from our subset actually had prior COVID-19. And when we looked at those patients, they usually had very, very high titers. So the prior COVID-19 infection followed by vaccination really pushes up the titers to super high levels. So I just mentioned that this was done basically, by a very, very passionate group of hem-onc fellows, helping us with zero funding. Honestly, this study was done, with no monies whatsoever, and we were able to identify, in the first paper in the literature on this particular subject, that most patients with cancer meant very solid immune responses to COVID vaccines, especially those with solid tumors on immunotherapy, endocrine therapy. But yes, indeed, we can define those very specific subgroups who might respond less well, and they follow a scientific logic as you would hope for in this particular case, with the most immunosuppressive therapies easily identifiable. Those are the patient subgroups that we need to then focus on afterwards. Well, if they didn't respond to the first set of vaccines, how can we help them better, with further efforts? Observations, active chemotherapy didn't seem to make much of an impact. Later on, from larger cohorts of patients, it does seem that maybe a minor impact can be from active chemotherapy as well. But basically, most patients, we felt, could be very reassured the vaccines were overall very effective. And I failed to show any slides on this one, but they were also very safe. Nobody had any major side effects to report. And that is true, since that time for third and fourth dose vaccinations as well. So safety is definitely there, and efficacy for the largest majority of patients is there as well. Since that time, many studies have been published on the same subject, and it's always nice to see that your data is being confirmed. Basically, that's what all of these studies show. A typical patient with cancer, will should anticipate a very good response to the vaccination. But yes, indeed, certain subsets will do differently. So vaccinations are super important, and they need to be pushed. At the same time, some patients will not benefit. And as we published this first experience, well, we said, can we take a proactive measure for those patients we identified who will not respond, the CAR T-cell, anti-CD20, etc., the non-responders, and we were able to convince a bunch of agencies, including actually the FDA, to help us set up what we call the booster study, and this turned out to be the first American booster study for third dose vaccinations, using the Pfizer vaccine, which at that time our chief medical officer was willing to give us. He gave us 100 doses to complete a study within the hospital, using hospital supplies, allowing us to proceed with this. And this was then supported by the Lymphoma and Leukemia Society. So suddenly we actually had a little bit of money to have this study go forward. Opened it in August, first week of August, and the next day or 2 days later, the CDC changed their guidance to allow a booster shot for immunosuppressed patients, basically making our study near impossible to complete, with that CDC change. So we very, very quickly had to redesign it. We very rapidly adapted this study to allow not just the most immunosuppressed, but others to participate as well, for us to be able to learn, because otherwise there was just no further recruitment as the third vaccines became available fairly widely for the immunosuppressed. So with that little bit of a quick change, we were able to actually complete the booster study, and this was published in Cancer Cell back in November, and again was the first of its a series of similar studies to be published as a longitudinal cohort of patients, where we basically accepted patients who were negative after the first set of vaccinations, as well as than the seronegative cohort, meaning no antibody detectable after the first sets of vaccines. as the primary endpoint of the study, hoping to see a seroconversion rate of more than 30%. So that's how the study was powered. And basically, we gave them the third dose, and then a month later, we rechecked their antibody levels and looked, have they converted or have they improved, their antibody titers. And we were fortunate enough that some of the patients who participated in this study came from our first study, meaning that we had antibody titers on them from earlier on. So we could actually check on, was there some waning of immunity over time between April, May of 2021 and September, October of 2021. And this sets up the two cohorts that you can see here, the booster vaccine study and the follow-up immunity study on the right-hand side. I think this is actually basically just the same. So just like in previous studies, you'll see a diverse group of patients, both in terms of malignancy types. Now with a bit of a focus towards heme malignancies, as most of the seronegative patients will be patients with a hematological malignancy, as well as usual, a split between prior vaccine types, Pfizer, Moderna, or Johnson & Johnson. What we've noticed is the following. First of all, you can see antibody titers back in spring of 2021, fall of 2021. And what you can see in 4 to 6 months, there was a major drop-off in terms of detectable antibody titers. And as much as at that time, the statement was it doesn't matter because you have memory B and T cells, it turns out it actually matters a lot, that there's waning of immunity, leading to all the breakthrough vaccinations through the Omicron wave, et cetera. So I think this was an important observation that, yes, indeed, there's a significant, waning. And if you start lower, heme malignancies, that waning will make more of an impact as you dip into a range where suddenly that immunity is not going to hold up in the case of a new infection. An interesting observation, and I think actually, true, based on larger cohorts, is that as much as there's waning, the Johnson & Johnson started out a little bit, more poorly, but it seemed like it had a little bit more staying power as to antibody titers. Now coming to the booster cohort of patients, what we could see is a very nice boosting of overall activity, both in terms of solid tumors and liquid tumors, except for one group, and those were the patients who had received rituximab. If they received anti-CD20 therapy, rituximab, more than 6 months prior to vaccinations, they did seem to have a spike in terms of antibody titers. If they received it within that period of time, they just could not respond. And that's something that again has been confirmed since. We also had a chance to now look at T-cell assays that we had a little bit more money to spend. And this is a typical T-cell assay looking at a stimulation test similar to the quantiferon tuberculosis test, looking at specific T cells that can be instigated by the antigen to release interferon. And what we could see here is that, yes, indeed, not just that most of our patients had detectable T cell activity prior to the booster vaccinations, but the large majority, as you can see from this slide, now has a nice rise in those T cell assay results after the boosting. And I also want to say here that the primary endpoint of our study, the 30% seroconversion, we reached, and not just that we reached, we beat it by 56%. So more than half of the patients who were seronegative to begin with were able to seroconvert to a positive antibody test by the end of the study at 4 weeks. Lastly, as I mentioned, we had a couple of patients, 28 to be specific, who had antibody levels in the spring prior to the booster and after the booster. And what you can see is that the boosters don't just, re-energize the immune system back from that waning of immunity, but there's kind of an overshoot. There's very aggressive activation of the immune system with the boosters, yielding, the recommendation that most patients who are immunosuppressed, and by now, we believe practically everybody should get a third booster shot. So the conclusion of our study, which was published in November, suggested that yes, indeed, there's waning of immunity past 4 months for standard dosing. Additional booster dosing, can make a difference and can yield detectable T cell activation as well. But patients who had received anti-CD20, failed to mention Bruton tyrosine kinase inhibitor therapy, another B cell inhibiting agent, have blunted effects and will need some additional ways of protecting them. So third time's the charm. That's what we kind of learned from our work, and kind of led to different guidelines that we developed based on our data. Which are the patients who we should really push towards getting the third booster dose as it became more widely available. And certainly patients who are seriously immunosuppressed, had received those immunosuppressive therapies before, or too much time passed from the prior vaccine, seem to be very logical candidates for booster dosing. But then as we developed this strategy, suddenly the pandemic shifted, and the pandemic shifted with a variant emerging, the Omicron variant, which now has more than 40 extra mutations, 20 plus of them impacting the ACE receptor binding domain, the spike protein, yielding now very, very, very different enemy. And now we learned, from this Omicron crisis that, you shouldn't be picking and choosing as to who should get the booster shot. Everybody should get the booster shot. In retrospect, of course, it's easy to say, but I was actually in Europe, to give a little talk, and as I was flying back, that was the first week where a couple of Omicron cases were diagnosed in New York City. And then a week passed, and New York City just became flooded with Omicron cases in December, to the point that probably half of New York City got infected. So suddenly we were like looking at each other that, we might be in position again to go back and understanding, now after all these vaccinations with a new wave of COVID-19, what has changed as to the actual impact of COVID-19, not the vaccinations, on our patients with cancer diagnosis, leading to this paper that was just published a couple of weeks ago. Again, the first paper to my knowledge, looking at now case fatality rates after the Omicron variant overwhelmed New York City and our healthcare system again. We collected cases between the 1st of December through middle of January. I had follow-up on each of the patients for at least 10 days to make sure that there's reasonable follow-up. And what we found, I'll show you in a moment, but this is kind of our case collection. We also have controls from our health system, which is a very large health system, and we had more than 12,000 patients with COVID-19 diagnosed within the health system at the same time. So we use them as kind of our internal control as compared to our cancer cohort. The cancer cohort being 200 and some odd patients, 285. Again, a diverse split of patients, malignancy types. And what we found, first of all, that the case fatality rate as compared to 28% with the first wave was 4.9%, so much better. And, you could say, well, maybe that's from the vaccines, maybe that's from just the Omicron being a milder variant. Regardless, it's definitely a much more manageable case fatality rate, but it still is 5% of your patients who will die from or with Omicron. So that's still a little more frightening than we anticipated. But when we looked at the very specific risk factors leading to the higher morbidity, mortality, clearly, again, age and comorbidities came out as very, very strong risk factors. And I just hope that you're able to see that slide. And when we look further, patients with metastatic active disease, seem to have a higher risk as well. And strangely, when we look, the vaccination status actually didn't stand out as a negative predictor of mortality. It didn't seem to be on the surface, very protective. And we were very curious to understand, why that might be the case. We also didn't notice any significant difference between solid and hematological malignancies now in this follow-up experience. So when we did, what we did then was a very deep dive as to trying to look at the chart of every single patient who died, trying to understand why is there still a significant mortality. And what we identified was very clear-cut in a way to me, who actually looked through these charts myself. About 1/3 of patients, were very advanced cancer cases who were, going to hospice or were dying in the hospital. But COVID-19 clearly was just an incidental diagnosis. Another 1/3 of the cases had very, very advanced immune suppression, very advanced HIV, things of that nature. And another fraction, seemed to be patients with identifiable reasons why they just didn't develop proper immunity. In fact, some of them had documented negative antibody levels, spike antibody levels. So again, it seemed like poor cancer status, poor immunity status, and then incidental infections might have tilted these numbers, might be major confounders that one has to keep in mind when looking at this data. And this is when we looked at our control group to kind of gauge this appropriately. And our control group was a little bit younger, 61 years old, was also much less vaccinated, 53%. Our patients with cancer had like a 70 to 80% vaccination rate. And here the case fatality rate was just 1%. And in fact, when we looked at these patients, what was obvious that here the vaccination status made a huge difference. So if you had double vaccinations, you had much less of a chance of dying. If you had triple vaccinations, you had 10% of the chance of mortality than a patient who was unvaccinated. And then we look back at our unvaccinated patients and trying to ask who were those patients, realizing that we had a major confounder that we forgot about. Most of the unvaccinated patients in our cohort were children who just couldn't be vaccinated because there's no recommendation. There was no recommendation for that age group. And of course, young individuals have a low risk of dying from cancer. So there was a major confounder as to vaccination status that we had to account for. And when we put that in the calculus and we put that particular issue in the calculation as well, then suddenly, including the cancer diagnosis, booster vaccinations and vaccinations came out as protective against COVID mortality. And we did that calculation in multiple different ways with a statistician who's like a magician who helped us through all this work. Of course, as each study, this study still has some limitations. We actually didn't have genotyping information. We just know that in New York City at that time, more than 95% of infections were from Omicron. And some patients, the vaccination status was just not easy to ascertain, or the New York City actually has very good documentation, fortunately, that helped us out. Also, as I mentioned, amongst the cancer cohort, the unvaccinated patients were just a small group, and they were majorly skewed, for pediatric patients, making any type of, major observations for the unvaccinated unreasonable from this particular cohort. So our conclusions, from this most recent study was that, yes, indeed, there's a much lower case fatality rate from the Omicron variant than from previous waves of COVID-19. The vaccines have a major protective effect, but there's still some additional mortality amongst cancer patients related to poor immunity or poor, response to immunizations as a result of their poor immunity. And of course, some patients will die with COVID and not from COVID when you have end-stage or terminal cancer diagnosis, and that needs to be also accounted for. And as we, publish this study, of course, it's always nice to see that for the larger population, yes, indeed, it's becoming more and more obvious that the boosters are very, very protective, 90% reduction of mortality. And now the fourth shot seems to be adding some extra layer of protection as well. So boosters are key for the broad patient population to be best protected. We need to continue to adjust, with further variants, and now the vaccines, will change, for these new variants in the coming months. So it's continued change and adaptation in our practices, but we're definitely ready for it. And with that, we're going on with our next phase of studies at this point. Now we have a bit more funding from the NCI, so again we can use a little bit better techniques. And now we're focusing on an expanded range of flow cytometry studies to look at memory T cells and B cells. We're actually looking at T cell receptor sequencing to look at clonality as a result of vaccinations. We're focusing on very special neutralization assays to understand variant level protection from the vaccines. And I think I'm a little bit out of time, so these slides I'll just skip through. And of course, we're hoping that this wave was the very last wave, and the pandemic will finally subside and settle down. Hard to project the future, but it's better to be prepared than just being naive. So we're continuing to work. We're continuing to work now on a 4-dose study. We're completing it. Actually, I think our patient came in today for a 4th-week follow-up on it, and hopefully we'll be able to publish results on that soon. Now looking at the antibody titers, T cell assays, neutralization, etc. We're also monitoring waning immunity from our previous cohorts. And as we have prophylactic antibodies that we can offer to the most immunosuppressed patients, such as the EU-shot antibody. We're looking at unique studies to look at are those antibodies actually protective for a patient population with the use of proper laboratory assays. And of course, any of such work, requires truly a team. And I could not have been more lucky to have a super passionate team, mostly consisting of an incredibly energetic and smart group of hematology oncology fellows who've been just tremendous in helping us out. And with that, we're ready to continue to do our work, both in the clinic as well as research-wise, to provide our cancer patients with the best PPE to prevent, to protect, and to enable in incoming waves of the pandemic. And I'll stop with that.
Thank you, Dr. Halmos, for your informative presentation. We will now start the Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen. Now let's get started. Our first question, policies are changing quickly, for example, as to masking requirements. How do you advise your immune-suppressed patients as to proper protective measures?
Yeah, that's a very important question, and also a question that, of course, each day will have to give a bit of a different answer to as policies do change. And just this week, of course, there's been a major uproar in the United States about lifting of mask mandates on flights. And you can argue, one way or another as to whether that was the right decision. But as a clinician, we need to protect our patients regardless of what the policies are. And yes, indeed, there's a couple of things that we need to know about. Of course, promoting vaccinations is key. So making sure that your patients are up to date with all their vaccines. And now I think with these changes as society opens up, which is good in many, many different ways, making sure that those 4 doses are given to the proper individuals will be very important. But also, of course, as patients move around in their communities, I think we just need to recognize that, active protection will be important. You cannot rely on other members of the society at one point. And good masks and 95 masks are very protective, in public transportation. We've learned that as physicians, if we use our N95s well, we didn't get infected. And also the most at-risk patients can actually ask their doctors to see if, they could be candidates for these antibody therapies, prophylactic antibody therapies that have been approved. Of course, some of them don't work for certain variants, so that's just something that has to be kept in mind, something to discuss with your clinician. And lastly, by any chance you've been exposed or, you have symptoms, early testing, and then again, pushing your healthcare team to make sure that you get offered proper treatment, early treatment for COVID-19, such as now we have approved medicines, such as Paxlovid, that's available. Might not be the easiest always to obtain, and there's definitely some contraindications and drug interactions. But now we have better measures to protect our patients, and if we identify the vulnerable properly and prepare them, train them, educate them properly, I think we should be able to, help them through any upcoming, major change in terms of policies.
Great, thank you for that. Another question, we have someone saying, thank you for sharing your seminal work, Dr. Halmos. Have you observed any protective, as opposed to risk, factors against COVID-19 infection or outcomes, example, severity, lethality if infected, in cancer patients prior to vaccination? This is even more important given the immunity waning effect.
Yeah, that's a great question, and I gotta say that as we were running these studies, I was so curious to see. We have now medicines that don't suppress the immune system but activate it. The new wave of successful medicines in oncology are immunotherapeutic agents, checkpoint inhibitors. I was super curious to see. We always see higher titers of antibodies and maybe a protective effect of these checkpoint inhibitors. I don't think we've truly seen that. They are certainly not impairing, the immune system's response, but we haven't seen a major protective effect. So it's good news, that patients receiving those therapies are not in any worse shape than others, but I don't think we've identified any very specific factors that are specifically protective.
Thank you. Another question, is there value for routine testing to understand COVID immunity on the level of an individual? If so, what specific population should be targeted for testing?
Yeah, that's an excellent question, and I got to say, as a practitioner, I'm kind of dismayed that there's no society that's come down hard on this at all. Because in reality, as you could see from the data, I mean, there's tests available. In fact, a gazillion, patients are asking them left and right, can you check my antibody level this day, that day? Are those truly helpful, and for whom? And I would think, although I'm definitely not a heme malignancy expert, but I think that the population most at risk, patients who had received the anti-CD20s, stem cell transplant patients, I see no particular reason, not to use these antibody test levels to see, have they developed some definable immunity? And patients who are seronegative, those we really you need to warn, you need to educate, you need to train, you need to prepare, to be the best protected. So I would think that there's some real value for some of those highest risk individuals, but there's no real guidelines as of yet, and that's very slow. I mean, we've been in this pandemic for 2+ years, so we should be able to be ready with those, but no clear guidelines from societies as of yet. I would love to see them.
Okay, and we'll wrap up with this question. So now that the fourth dose is approved for certain individuals, how do you advise your patients as to whether they should receive it?
Yeah, that's a great question as well, which I struggle with every single day as a clinician, as patients come in and say, I really didn't want the vaccine, but you convinced me to get the first and the second and the third. Do I really need to get the fourth as well? And again, society, CDC are not providing great guidance as of yet. What we do know is that they're authorized for patients above the age of 50, the immunosuppressed. So especially as society opens up and there's more of a chance for exposure, there's more of a chance for risk, I think more and more so we should just advise, most of our patients who are candidates to receive it. But if I needed to give you a sense of, who are the most important candidates, the clearly identified age, the clearly identified comorbidities, and seriously immunosuppressive conditions as major risk factors. So an elderly patient who's frail with an active cancer diagnosis, or a patient who received highly immunosuppressive therapies, I think it's a must in a way to follow the guidelines, follow the authorization, and offer them a fourth dose. Maybe somebody who's 50 and had early stage breast cancer and has never received cytotoxic therapy, this recommendation is not so strong. So I think we can nuance it, but more and more so, especially as public transportation will be riskier, we should probably just go ahead and then offer fourth vaccinations to most of everyone who can receive them.
Thank you for that response. And thank you, Dr. Halmos. Do you have any final comments for our audience?
No final comments. I'm just so glad that I had a chance to kind of share this information, and I'm glad to have spent the last hour with you guys.
Thank you again for your time today and your important research. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, or those submitted during the on-demand period, will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand for 2 years until April 21st, 2024. Labroots will alert you via email when it's available for replay. And we encourage you to share that email with any one of your colleagues who may have missed today's live event. Until next time, goodbye.